Welcome to today's Explainer. Today, we're taking a deep dive into male sexual dysfunction, but we're going to approach it a little differently than you might expect. We're going to strip away the stigma and treat it simply as a fascinating, highly complex neurovascular machine. Because honestly, when we take away the embarrassment and just look at the raw biology, we uncover some incredible insights into how our nervous and cardiovascular systems actually talk to one another.
Okay, here's our roadmap for today. We'll start with the scale of the issue, then explore the anatomy of an erection. From there, we'll uncover the ultimate warning sign, discuss mind versus body, and finish up with first-line fixes.
Section 1. The scale of the issue, epidemiology and prevalence. We're starting right here with the data to completely strip away that stigma I mentioned and prove just how incredibly common this condition actually is.
Get this. According to the Massachusetts Male Aging Study, a staggering 52% of community-dwelling men between ages 40 and 70 experience some degree of erectile dysfunction. That's literally more than half the guys in that age bracket. So if you thought this was some rare mechanical failure, well, the numbers are telling a very different story. This isn't an anomaly at all. It's a highly prevalent biological reality.
Now, if we take that 52% and break it down into specific levels of severity, it reveals a pretty fascinating trend. We've got 10% experiencing complete dysfunction, 25% with moderate, and 17% minimal. But the absolutely crucial takeaway here, the moderate to severe cases actually doubled as men aged from 40 to 70. Basically, the older the machine gets, the more likely the components are to wear down.
Moving to Section 2, Anatomy of an Erection, Plumbing and Wiring. To understand exactly how the plumbing and wiring of this machine breaks, we first need to zoom into the microscopic level and see how this complex event actually works.
Think of this cascade like a sequence of falling dominoes. It all starts with enact nerve activation, which leads directly to the release of nitric oxide. Now, that nitric oxide is the critical trigger for producing a molecule called cGMP. What does cGMP do? It forces the smooth muscle to relax, which, ironically enough, is exactly what allows blood to rush in and expand the tissue. Finally, this expansion physically compresses the veins, trapping the blood inside in a process called venous occlusion. But here's the catch. If even one domino is missing, like nitric oxide, the entire chain reaction simply won't happen.
This perfectly illustrates the two opposing nervous systems we've got at play here. The parasympathetic system, running out of your lower sacral spine, manages the rest and erect phase. It kicks off that whole domino cascade we just talked about. Meanwhile, the sympathetic nervous system, located higher up in the thoracic and lumbar spine, is your fight or flight system. It does the exact opposite. It triggers ejaculation and then returns the body to a flaccid state by contracting those blood vessels. So these two systems have to work in perfect, alternating coordination.
So, when the system does fail, it's not a character flaw, right? It's just biology. And that failure usually falls into one of three mechanical categories. First, a failure to initiate, meaning the brain or nerves just never send the signal. Second, a failure to fill, meaning the arteries might be too clogged to deliver the blood. Or third, a failure to store, often called a venous leak, where the smooth muscle doesn't relax enough to trap the blood, so it just drains right back out.
Section 3, the ultimate warning sign, cardiovascular links. Let's explore what this mechanical breakdown is actually telling us about the rest of the body. Because it turns out a failure in this specific machinery is rarely just an isolated incident.
This is vital to understand. Erectile dysfunction is considered a sentinel symptom. It shares the exact same underlying pathology as heart disease, specifically endothelial dysfunction, which is damage to the inner lining of the blood vessels. Since the penile arteries are so much smaller than the coronary arteries in your heart, they clog up first. So, it acts as a blinking red warning light on your body's dashboard, signaling that wider, hidden vascular disease is already quietly underway.
Just take a look at this disease timeline. It really shows why this matters so much. Endothelial dysfunction begins right at year 0. By year 1, the smaller arteries are affected and erectile dysfunction shows up. But the larger coronary arteries? They're still functioning just fine at this point. It takes several more years of silent progression before symptomatic coronary artery disease actually strikes. This gives patients a massive, critical window of time to address those hidden heart issues before a heart attack ever happens.
Now, the biological cascade we discussed earlier gets severely disrupted by these high-risk factors. And notice anything? They are the exact same risk factors for heart disease. Smoking, hypertension, low HDL cholesterol. They all just wreck your blood vessels. But diabetes is the absolute biggest offender here with a 35 to 75% incidence rate.
Why? Because diabetes is uniquely destructive. It damages both the nerves that send the signal and the blood vessels that do the filling, all at the same time. Section 4. Mind versus body. Diagnostic evaluation. Now that we understand those physical risks, how do doctors figure out if the broken domino is in the physical body or if the blockage is actually originating in the mind? This right here is the fundamental diagnostic question for any clinician. Is it organic or is it psychogenic? To find out, they use a genuinely fascinating, purely biological method called the nocturnal penile tumescence test, or NPT. This test completely bypasses the conscious brain to see exactly what the machine can do on autopilot. Comparing these two profiles makes the difference crystal clear. Healthy males naturally have erections during REM sleep. So if those nocturnal erections are preserved, we know the physical machinery, the plumbing and wiring, is entirely intact. This points straight to a psychogenic or psychological block, which usually has a sudden onset and is situational. However, if those nighttime erections are absent and the problem has been gradual and consistent, the clinician knows for sure they're dealing with an organic, physical breakdown.
But we've got to keep in mind that the mind and body are intricately linked. You just can't separate the two. In fact, almost all men with organic ED eventually develop a secondary psychogenic component over time. Even if the root cause is purely physical, the stress and performance anxiety add this thick layer of psychological friction that really compounds the issue.
Section 5. First-line fixes. Pharmacological interventions. Let's look into the pharmacology to see exactly how these highly engineered drugs interact with our biological dominoes to get the machine running again.
The absolute first-line tier of treatments belongs to a class of drugs known as PDE5 inhibitors, and it's wild how much they vary. So Denafil, the oldest one, has a short half-life but can occasionally cause this crazy blue-tinted visual halo because it slightly cross-reacts with an enzyme in the retina. Tadalafil stays in the system for a massive 17.5 hours and can cause back pain, while Avanafil is heavily engineered for speed, kicking in within just 15 to 30 minutes.
Now, remembering our domino cascade from earlier, it's vital to understand what these pills actually do. They do not initiate the process. All they do is block the enzyme that breaks down cGMP. It's essentially like putting a stopper in the drain to maintain things. But here is the major catch. They absolutely require your body to produce that baseline nitric oxide to knock over the first domino. If a patient has severe diabetic nerve damage and can't produce nitric oxide, these pills simply will not work no matter how high the dosage is.
Doctors also have to audit the patient's existing medications because sometimes the medical system itself is what's throwing a wrench in the gears. Certain antidepressants, particularly SSRIs like paroxetine and escitalopram, carry a really high risk of causing medically induced sexual dysfunction. Sometimes just switching a patient to lower-risk alternatives like bupropion or mirtazapine can completely fix the mechanical failure without even needing to prescribe a new pill. Now, I need you to pay absolute attention to this stark warning, because both PDE5 inhibitors and nitrate therapies, which are often used for chest pain, aggressively open up blood vessels. Combining them is a strict absolute contraindication. Taking them together acts as a massive double multiplier on blood vessel dilation. This causes a sudden, severe, and potentially fatal drop in blood pressure. The mechanics here are incredibly powerful, and they absolutely demand respect. So understanding the mechanics of the body doesn't just empower us to fix the plumbing, it completely reframes how we look at our own health. A breakdown in one area is rarely isolated, it's a signal. We've seen how endothelial dysfunction shows up first in the smallest vessels before it ever threatens the heart. And that leaves us with one critical, potentially life-saving question. If your body is flashing a warning light on the dashboard, are you paying attention or are you just trying to cover it up? Thanks for joining me for today's Explainer.